The Medical AI Podcast.
Welcome to the Medical AI Podcast with me, Dr. Felix Beecher. Strap in for a 30-minute thrill ride of big ideas. Under capitalism, a company has to make money. But a big problem in medical AI is that few companies are. Most are burning up venture capital, and profitability is very hard to achieve. One key reason is that it is extremely difficult to obtain government reimbursement for the use of medical AI products. But a small number of companies are making progress here. What can be learned from them? And how would a shift in reimbursement change the sector? Well, these are all very important questions. I'm delighted to have Chris Wood join me for this discussion. Chris, would you please introduce yourself? A very warm welcome to the podcast, by the way, and explain a little bit about what you do and your company.
Sure. Thanks for having me, Felix. So I started out, I guess, as a medical physicist. I worked at Moffitt Cancer Center during graduate school, working on actually AI for medical imaging way back in the late 80s. Then I worked for big companies, Picker and Siemens in the 90s, sort of breaking everything up by decades here. I started a company called Confirma in the 2000s, and we were actually the first company to get CAD approved through the 510K pathway for medical imaging. That company sold to Merge Healthcare. Then I started Clario, which is a work list workflow company in the 2010s. That got sold to Intelerad, and most recently I've become CEO of RevealDX, which has been occupying my time for the last 4 years or so.
Good. All right. So, Chris, now I've already referred to reimbursement as a problem. First of all, do you think I'm right about that? And if so, why? And if not, why not?
Well, you know, when I sold Clario, I was looking for an AI company that could actually follow in HeartFlow's steps. As you may know, HeartFlow sort of kicked off things with medical imaging AI reimbursement. They got approval in 2018 for fractional flow reserve CT through a Cat3 code, which is a temporary code. I really thought this was a game changer. So I started looking around and found a company that was, I thought, building technology that could also be approved through these same types of pathways. It was having a tough time because of COVID. So I gathered a team of investors, and we purchased that company in March of 2021. And, it was specifically pulled out because I thought we could get reimbursement. And that, coming back to your question, the problem with a lot of companies in medical imaging AI is the source of revenue was efficiency gains. And I thought the future was going to be reimbursement. And I still actually believe that is the best way to fund this industry. So that's kind of the problem we were trying to solve with this type of company, is bringing more money into radiology AI through reimbursement and sort of building momentum around this whole space by doing that.
Okay, so now we need, I think, to de-jargonize the conversation a little bit. Now, could you explain exactly what reimbursement is to the uninitiated, and could you just summarize in layman's terms what the current payment pathways are? Sure.
So most people are probably familiar with sort of the standard pathway of getting of physicians getting paid for a service, and that's in the Medicare physician fee schedule, sort of the standard pathway. These are CPT codes that are approved and paid. If you go to a doctor's office, that's how you get paid. There's only 2 medical imaging AI applications that fall into that category. One of them is HeartFlow, which started out as through a different pathway and now is in the Medicare physician fee schedule. And the other is not radiology. It's an imaging AI application for imaging of the retina. And it's paid via CPT codes and an RVU rating. The next way that you get paid in the Medicare system is something called Inpatient Prospective Payment System, the IPPS. And that's based on ICD-10 codes. So the amount of payment is set by that. There's also a subset of that called the New Technology Add-on Payment. And we've seen one medical imaging AI application get approved for payment. That's the large vessel occlusion product from Viz.ai. There's also been 2 rejections. So the Rapid Aspects and application and AI Doc's briefcase for pulmonary embolism, those were rejected for payment using the IPPS. And then the most successful is what's called the HOPS. So this is the third pathway to reimbursement. It's the Hospital Outpatient Prospective Payment System. There is a pathway within there called the New Technology Ambulatory Payment Payment System, so NTAP, to be not confused with the New Technology Add-on Payment. This is the New Technology Ambulatory Payment. And we've got 5 or so approved for payment using that pathway. We've got Fractional Flow Reserve CT, which was the original heart flow pathway. Liver, fat, and iron has been approved. That's the MRI application. Lung cancer. So this is nodule triage, which is what our company is doing. And then coronary artery characterization. So this is like a clearly type application. These are all temporary codes. And the idea here is that you start out with this HOPS payment system with a temporary code. You check to see whether or not people are using the code over the next few years. And then you consider whether or not there's sufficient evidence to elevate it to a permanent Cat 1 code, which is, like I said, there are only a couple that have made it that far, but there are a few that are now paid through this HOPS mechanism. You get something called an ambulatory payment classification in this route, and that determines your level of payment. Our product, for example, is approved at level 8, so that is about $600 or $700 payment for that application.
Okay, so that's a beautiful summary. Let's come back to the concept of problem, though, because
Yeah.
I think probably one of the biggest complaints in the industry is that these kind of reimbursement pathways are difficult to achieve, and this
Yeah.
is a real struggle for the sector as a whole. Could you unpack that a little?
It is a struggle, and there's been a lot of confusion. You got to remember, this is pretty new. Medicare doesn't really move that quickly, and AI moves a lot faster. There's also 4 companies. Kind of the way I look at the industry is there's 4 different types of companies. You have companies gathering data and doing data labeling for medical imaging AI. And then you have foundation models. And then you have delivery platforms, right? So marketplaces and things like that. And then, of course, the applications themselves, which sit on top and use all of those services from those other companies. Well, like it or not, all of these B2B vendors, right, that are supplying services and software to companies like us, all of this needs to be funded somehow, right? And the apps are the ones who actually collect the cash, and getting it through reimbursement is going to fund the industry a lot better than trying to fund the entire thing through efficiency improvements and having the radiologists pay for this themselves. I mean, there's only so much you can squeeze out of a radiologist when it comes to efficiency, right? Since reimbursement's funding the entire stack, and only CAD-X and some CAD-T, that Viz.ai application is kind of a CAD-T type product. CAD-E is the lion's share of the FDA clearances, and they're trying to fund those mostly out of efficiency. Payers don't want to pay for something that a radiologist is already getting paid to do, and finding a finding is something they get paid to do, right? So the idea is make them faster. There's really a kind of a lack of the CAD-X type products on the market that can actually qualify for reimbursement, because what you really need to do is show that you're improving patients, even on the outcomes level in some cases, and you're saving cost. That's the only way things are going to get paid. You can't You can't go to a payer and say, hey, we're going to make radiologists 10% faster. Will you pay for our product? And their response, if you did that, would be, okay, only if we can pay radiologists 10% less. And that's not that's not the goal here, to be, kind of net even. The goal is to try to improve the value of the report that the radiologist is creating and somehow translate that into some sort of payment that can then fund this entire industry, which will, rising tide will raise all boats, right? So we want all of this industry to be benefiting from the money that's coming in from insurance because we actually are adding value.
So now some people might be thinking, why is the medical field special in this way? Why should there be such a thing as government reimbursement at all? Why can't these companies stand on their own 2 feet and operate within more of a free market? What would you say to that?
Well, in the U.S., Medicare is really the big source of funding, and a lot of the private payers follow what Medicare is doing. Now, it's entirely possible that private insurance could pay before Medicare, but we haven't seen a lot of that yet. I guess there have been some cases where private insurance. And there's also, I guess I'd be remiss in not listing sort of these other ways that the industry, medical imaging AI, could be funded. One is patient pay. And, we've seen groups like RadNet do a really good job with that. I think they reported in their last year's report about 20 million in revenue, I think, from patient pay. They've been out purchasing companies to increase the number of AI offerings they can provide to patients. I mean, I think the patient pay option is interesting, and they've certainly had some success there. There's also some shortcuts that have been created. So one is something called breakthrough designation by FDA, which has been linked to automatic reimbursement a couple of times. In 2019, we saw that get approved. And then in 2021, get shot down again. And then we had a 4-year reversal. And I think we're supposed to get some news about that in the summer. And then recently, in April of this year, we had the Health Tech Investment Act get introduced, which was sort of a out of the blue global, a bill that would authorize payment for everything related to AI that was FDA cleared. I may be pushing it a little bit beyond what it specifically says, but close to that. But there's no word from groups like the ACR yet on whether or not that's actually going to be endorsed, because it does seem like that would kind of be a little bit disruptive in its current form. Having sort of the floodgates opened, right? And all of these AI applications being introduced and reimbursed at once, that would be a real shock to the system. So I think there's got to be kind of a better way than doing breakthrough designation and this Health Tech Investment Act, maybe some blending of the two ideas. The idea is that, in general, politicians in the United States, and I think elsewhere, are realizing that the current system is pretty slow moving, and AI is very fast moving, and we don't want to hold back patient care and limit patient outcomes through our reimbursement system. So people are struggling with how to get this stuff to market, get it reimbursed in a way that's reasonable, but also fast.
Okay, so this problem of reimbursement being a key bottleneck for progress of the sector in general, could you give us some kind of idea of the importance of that problem?
Yeah, I think, like I said, if you look at RSNA, we've got 100 or so companies that present at RSNA this year. We've got all these supporting companies that do things like provide now, foundation models and data and all these other things. Reimbursement is needed if we're going to sort of support that entire ecosystem. I think you can say that building an app that goes through the CAD-E pathway can be done relatively inexpensively, right? You can get something to market. And if it's just as simple as making a radiologist 10% faster at reading a certain type of exam, there's probably an ROI for everybody there. But if we want to do something really significant with medical imaging AI, we really want to change, how radiologists work. And eventually, if we really want to get to the point where medical imaging AI is reading some of these reports automatically, then we're going to need reimbursement to start flowing in to fund the industry, get investors excited, getting more of these companies to achieve exits, and building a real ecosystem around it. And I think if you ask most radiologists, if they would mind if 20% of their chest X-rays that were normals were read by something else, I think a lot of them would say, sure, I'd take that, right? Because the number of exams keeps getting bigger and bigger. Yeah. The number of radiologists isn't increasing as fast. All these numbers as well as anyone, right? So, I think if we want to get to that point, there's going to be more capital that needs to be invested, and that needs to come from investors, but investors will only come if the reimbursement is there, providing additional capital for the industry, as we try to accomplish some of these bigger goals.
So now if you were sitting in front of a committee in Congress, that's exactly the kind of pitch you might make, right, I think?
Yeah.
But how do you see the current direction of travel politically at the moment in the US?
Yeah, I think the U.S. is leading the way right now. We spend, about 17% of our GDP on healthcare, I guess. We've seen this HOPS pathway open up, which is an interesting pathway. It's a temporary code. I'm not familiar with equivalent systems in other countries that allow for this type of quicker route to reimbursement, albeit temporary, that allows the market to kind of figure this out. Some other countries, we are seeing progress. In the EU, for example, we were able to, with our partner ContextFlow, achieve reimbursement from a payer in Germany, which services a fairly large population. That's a country that spends also a fair amount of their GDP, about 12%. On healthcare. With that type of reimbursement, though, in most other countries, it's more similar to what would need to be done to get a Cat 1 code in the United States. So getting any type of reimbursement at all requires fairly extensive health economics analysis, as well as a number of clinical papers that speak directly to the long-term outcomes for these patients, right? So those are possible. We've shown that it is possible, but we are the first and only so far to get medical imaging AI reimbursed in all of Europe.
We will come back to that, Chris. Now, before we do, however, let me just ask you, I think probably the case for medical AI is made all the time, it's very familiar, but what kind of arguments are used against the greater introduction of reimbursement?
Yeah, I think, we've seen some of the pushback. Mammography's been the first, right? They were the first to use computer-aided detection. And I think that the primary argument against reimbursing is that once reimbursement is offered, people will start using it, maybe more than would be indicated. In 2002, less than 5% of mammograms were interpreted with CAD, right? But by 2008, 74% were interpreted with CAD. And that was a big cost to the U.S. healthcare system, about $400 million a year. So, it's possible that you get a little bit of this the tail wagging the dog effect, right? Where if you have reimbursement, people start using a product, even if they, for a particular case, don't feel like it's adding much value. I mean, I've talked to radiologists who, just as a matter of course, they use CAD for mammo every single time, and some of them believe it's really not helping them much at all. And that is the concern. Now, at a population level, there's plenty of data saying that CAD for mammo does help,
Yeah.
right? But there's this counter argument, which pops up time and again, that maybe it's being used too much. In which case, you're kind of encouraging people to do something which may or may not be adding value in a particular case, right? And we all want to squeeze as much value as possible out of the U.S. healthcare system. So these sort of global decisions about reimbursement can be criticized in that way.
All right. Well, look, let's turn to your company, RevealDX, and there's a
Right.
particular reason why it's you that's talking about this issue rather than somebody else. So, tell us about your company, its offering, and then let's talk about how RevealDX stands in relation to the issue of reimbursement. So, let's start off by describing your offering.
Sure. I mean, the product is really simple. Radiologists in the United States find millions, literally millions of lung nodules every year. And the concept here is that you click on the lung nodule and it gives you a score. And that helps you assess how risky that nodule appears to be. It's looking at, and our technology is probably similar to other technologies, but our technology looks at the nodule in 3 dimensions, looks at the surrounding parenchyma. We look at thousands of different features. And then we render a number, which can help be used to triage that nodule effectively into an appropriate follow-up category. Right now, we are approved for use in the EU through MDD, which we're actively converting to MDR. In the United States, we are pursuing FDA clearance, which we expect to get this year. And there are reasons why this is becoming a kind of a hot topic right now. One is that lung cancer screening has been approved for payment in the U.S. So, with that, you get systems in place that monitor and track nodules. Turns out incidentally found nodules are almost as likely to be cancer as ones that are found in screening programs for a variety of reasons. So they need to be tracked also. So now you have all this tracking occurring, right? You have higher resolution CT scans, which means that now about 40% of all chest CTs, you find a nodule. You get AI, LLM-based products like Think Health and Epic and Eon that are looking at radiology reports, making sure you don't miss a nodule and that you follow it. So now you've got all these nodules to follow, and we provide one way of maybe organizing all of this data in an objective way that will allow you to accomplish your goal, really, which is to try to catch these cancers as early as possible without doing a ton of unnecessary biopsies. I mean, you don't want to stick a needle in every lung nodule you see because you're talking about lung tissue, right? Complication rate is pretty high. So when looked at in the broader sort of clinical context of what our customers are dealing with, they're dealing with this deluge of nodules, also accentuated by really good technology like computer-aided detection of lung nodules, right? That increases the number of nodules you're finding as well. Combined with all the other forces, we've got this deluge of nodules coming down. We have to track them. What are we going to use? Are there any tools that can help with this whole process? And that's essentially what we're trying to build.
Sure. Okay. Now, you've had some success as a company in terms of reimbursement. Could you talk us through how that has come about and what it is?
Well, like I said, with our partner, maybe backing up a little bit. Like I said in the beginning, one of the primary reasons I went into this company, got involved, I was not the founder. Michael Calhoun, who's our CTO now, was the founder of this company. He saw this application of AI before, I think, anyone, and was working on the product for a while. And then, when I got involved, one of the primary reasons was because I thought it could get reimbursed. And the reason I thought that is because of all these market forces that I talked about, but also because of the fact that if you look at lung nodule triage from the perspective of screening, right, and from a health economics perspective, it's reimbursable. you look at the chest CTs are performed on maybe 100,000 patients, and then you do the analysis, and you're like, okay, how would we impact the number of patients, right, that might get unnecessary follow-up, or how would we impact the ability to detect early? And if you look at the clinical studies and you look at the impact of that, the numbers work out. It's worth paying for a tool like this. That's what we needed to convince the folks who were looking at reimbursement. I'd say that where we are right now is we've got one payer in Germany. We've got a T code in the United States. We certainly aren't there yet in terms of declaring victory, but I think this is showing quite a bit of promise from both a health economics standpoint and benefit from patients standpoint, which kind of go hand in hand, right?
Now, I'd imagine that lots of radiology AI companies are watching very carefully, and I think they'd be very interested to know what the main challenges are that you've faced. Could you talk about that?
Well, one challenge that is universal for CAD-E, CAD-X companies, we all face this, is generalizability. So acquisition techniques change. Protocols are not standard across the industry. It's exceedingly difficult, and you have to really take care to build medical imaging AI applications that will work wherever you install them. And we actually took this very, very seriously. We even did a test with a partner in France, clinical partner, who had data where they scanned a patient and then they varied the dosage by a factor of 10 and scanned the patient again. And we showed that so the protocol is completely different. And we showed that we're getting essentially the same number. We built our system sort of from the ground up, knowing that it could be generalizable. That's one very specific challenge. Another one is inserting into the workflow, which, as you probably know, is still not solved. That problem is not solved, even if you look at the platforms that are out there. Our industry decided to go with marketplaces and platforms instead of putting AI right into the PACS. So it's kind of looked at as kind of an add-on type of application. It's not perfectly integrated into the workflow, which you could achieve with tight integration with a PACS system. So that is going to limit adoption a little bit. This is why we designed our tool to be just one click or zero click, right? So that we don't have to have real extensive integration with PACS vendors in order to deploy this out into the world. And then the third is, like I said, the challenge of which tools do we buy off the shelf to build this? Which do we develop in-house? The standard product development stuff is also at play here, where you're trying to take some payment or some payment, either by the provider or the payer, and you're trying to divvy it up so that all the stakeholders in this ecosystem are covered. Like I said earlier, our product works best when it's in a lung nodule management program, when it's inserted into that program in a logical and rational way. A lot of providers don't currently have any advanced lung nodule management system that they're working against. They might have an Excel spreadsheet with a nurse navigator, but they currently aren't doing a good job tracking a lot of these nodules, some of them. And I would say that that's probably the first thing they should fix, right? And then insert AI into the system that you build around patient care, as opposed to sort of starting with AI, right? So sure. We're putting in mechanisms to kind of help some of these providers come up to sort of standard of care and have all the tools and software applications they need to do a good job of managing these patients. And then they're ready to go ahead and deploy something like ours, which will then take their system to the next level.
Got it. Okay, look, Chris, you've given a magnificent overview of this this area, and you've got a unique perspective. So I really appreciate that. Thank you, Chris. Look, before I let you go, however, I'm going to ask you my last question, which is your favorite current example of a medical AI system, nothing to do with your own. What would you say about that?
Yeah, I think that for me, especially with the topic here being reimbursement, I really feel like I need to say it's HeartFlow. I mean, they kind of broke ground here. They're a company that has been around for a long time. They helped triage in their history. I don't know the number, but I'm sure a lot of people away from the cath lab, which I'm sure those patients really appreciate. And they also did a lot to sort of break down the barriers to at least getting medical imaging AI started on the reimbursement path. Mm-hmm. And they've made it all the way to the Medicare physician fee schedule. So kudos to them. And like I said, if it wasn't for their success, their early success, I may have not even gotten involved in this field. And I'm really happy that I have. I mean, I've been working on medical imaging AI forever, off and on. And I feel like now we're at the point where we're starting to get some reimbursement, maybe a little bit of recognition for what AI can do.
Yeah.
So I would give them props for what they've accomplished.
Good. Well, they're going to love you for that. So, Chris, it's been such a pleasure talking to you. Thank you so much. Good luck with RevealDX.
Thank you, Felix.
Cheers. Bye-bye then.
Cheers.
Thanks for listening. Ping me on LinkedIn if you have any ideas on new subjects or guests.